So next up is Dr. Lillicrap, who is a professor in the Department of Pathology and Molecular Medicine at Queen's. After obtaining his medical degree from St. Mary's Hospital at the University of London in the UK, did some initial postgraduate training in England, and then completed his fellowships in internal medicine and hematology in Edmonton at the University of Alberta, and then at Queen's University. His research interests center on the molecular aspects of the hemostatic system, with particular emphasis on the potential for molecular genetics and molecular biology to address questions relating to pathologic hemostasis. And certainly I think that's how the international community would think of Dr. Lillicrap. His main focuses of interest of his research group are the development and evaluation of novel therapies for hemophilia A, investigation of the immune response to factor VIII, and characterization of the biology and pathobiology of von Willebrand factor. Dr. Lillicrap is a member of the World Federation of Hemophilia's Medical Advisory Board and a past chair of their research committee. He's also a past chair of the International Society of Thrombosis and Hemostasis, Scientific and Standardization Committee, and a member of the Council of the ISTH. And finally, he's a recipient of the Canada Research Chair in Molecular Hemostasis. He's a past associate editor of the journal Blood and serves on the editorial boards of Journal Clinical Investigation and the British Journal of Hematology, and has authored or co-authored over 250 articles. And he's going to speak to us today on whether we really need factor VIII and factor IX. Thanks, David.
Okay, good morning. So first of all, thank you very much indeed for inviting me to talk this morning. Jason, thank you for the introduction. So I'm going to talk to you this morning about something quite different, and that is these alternative treatments for hemophilia which don't involve giving factor. Here are my disclosures. Okay, so I think as everyone knows, really for the last 40 or 50 years, we've treated this condition by giving replacement of the proteins that are missing because of genetic disease. So cryoprecipitate, plasma-derived and recombinant concentrates have now been given. But since about 2011, there's been a significant push to try to deliver new therapies which are not regular replacement therapies. And on this slide here, you see that I'm going to talk about the two things that are in the center of the slide. You've heard about extended half-life products from Shannon. Dr. Tyler is going to talk about gene therapy. I'm going to talk about intrinsic Tenase innovations. I'll explain what that is in a moment. And then inhibitors of anticoagulant mechanisms. Okay, so this is the coagulation cascade that you either love or hate. Most people hate looking at this. But in the middle, I've drawn a red box around the area of the coagulation cascade that goes wrong in hemophilia. So there are a number of proteins contained within that box which are missing or deficient in the hemophilias. And of course, at the end of this, on the bottom left-hand corner, you get the derivation, the generation of a fibrin clot. Just above that, by the way, there's a factor called 2A, which is thrombin. I just point that out because towards the end of my talk, I'm going to refer to that in some more detail. Now, the middle part of that cascade is now amplified on this slide here. This is really a blow-up, if you like, a biochemical magnification of what goes wrong in hemophilia. So in red, you see factor IX, or the activated form of factor IX. In blue, you see factor X. And in yellow, in the middle, you see factor VIII. And these proteins are sitting on a membrane which facilitates the formation of normal blood coagulation. That membrane is either a platelet or sometimes endothelium or white blood cells. And if you look at factor VIII here, you can imagine that what it's really doing is acting as a scaffold to bring together factor IX and factor X in an optimal fashion. So in hemophilia, if you don't have factor VIII, you're now missing the scaffold. So here is the complex looking perfectly aligned and very effective. Here is the complex that's now falling apart because you're missing the factor VIII component. And you can see on the right-hand side here, I've told you that now, without factor VIII, there's a 200,000-fold reduced efficiency of making activated factor X when you lose the scaffold function of factor VIII. So about 15 years ago in Japan, a group of scientists at Chugai were ingenious enough to start working on what we call a mimetic protein. So this is a protein that mimics what factor VIII does, and it's shown in the middle of this diagram. By the way, we don't have pointers, I'm afraid, and nothing else to point with here. So, yeah,
there is a laser there if you want to point to one of the screens.
so the screens are actually in front of us. We can't actually. So we have to sort of tell you through the slides how to see things here. In the middle of this diagram, you can see a Y-shaped molecule, and that's an antibody. This is a bispecific antibody. It goes by the name of ACE910, or now Emicizumab. The bispecific nature of the antibody means that through one arm, and I'll do my antibody mimic here, through this arm, it's binding factor X. This is actually, please try not to infuse me. It may be painful for me and you. And through this arm, it's binding factor X. So this is a bispecific antibody binding the two proteins together. Okay. Thank you. Don't give up your day job, I guess, is the answer to that. Okay, so what this antibody does is that it mimics, in part, what factor VIII does. And if you look at the numbers on this slide here, the numbers relate to how efficient that complex is. The bigger the number, the better the complex is. So if you add factor IX alone at the top, this doesn't work at all. This is just a single protein. It doesn't produce activated factor X. At the bottom of the slide, you see how efficient this complex can be if you reconstitute the complex with activated factor VIII. There's a number there of 272,000. With Emicizumab, the efficiency is about 10%-ish. I'm not going to go into any more details, but suffice it to say that this mimic is very good, but it's not as efficient as factor VIII. It's about 10 to 20% the efficiency. Okay, so this is an antibody. You expect that you should be able to deliver this by subcutaneous delivery. It will have a half-life of about 20 days, which means you can give it infrequently. It can be given, as Dr. Carcao has already said, to patients with inhibitors, because inhibitors will not see this antibody as being foreign, and it won't worsen inhibitors either. So there are a number of very substantial benefits to this disruptive technology. Now, as it turns out, exactly 1 year ago, I mean, it's incredible how these things work out, in the New England Journal on the 26th of May last year, this paper was described, and I'll briefly report the outcomes here. So first of all, it's a small study. It's only 18 patients. They're aged between 12 and 59, and they were only followed for 3 months. So keep this in mind, small numbers, small duration of follow-up. What you see on this slide here at the top is that with the 3 different dosing cohorts going from 0.3 to 3 milligrams per kilo, you can see that there's a gradual increase in the amounts of Emicizumab in the plasma of these patients. And at the bottom of the slide, you see that the APTT measurement, this clotting study that we do, is very sensitive and is reverted to normal with all of these doses. Now, this is probably the most important slide to show. If you focus predominantly at the bottom left-hand corner in cohort 3, which is the higher dose, you see on the left-hand side 3 patients who had factor VIII inhibitors, so they're severe patients with inhibitors, and on the right-hand side without factor VIII inhibitors. And each of the bars represents the annualized bleeding rates before being given Emicizumab. And you can see that in each of those instances, there are bleed rates that go as high as 32. So these were very heavily bleeding patients. You don't actually see the bars beside that because they're all 0 or 4. So, I mean, there was a very, very significant response to Emicizumab therapy in terms of the extrapolated annualized bleeding rates, which were significantly reduced. Now, there were some issues. 3 of the original patients developed non-neutralizing antibodies to Emicizumab, but these antibodies didn't interfere with the pharmacokinetics or the pharmacodynamics of the treatment. So there were antibodies, but as you can see from the 2 graphs there, they actually didn't appear to interfere with the therapy. Now, the next 2 slides just deal with a bit of a speed bump in the development of this material, because in November of last year, there were public reports of 4 patients who developed thrombotic problems. 2 of those patients developed unusual venous thromboembolism, one in the brain and the other in the skin, and 2 patients developed what we call thrombotic microangiopathies, something like TTP, thrombotic thrombocytopenic purpura-ish. But all of these events were transient, and some of those patients are now back on therapy with Emicizumab. And if you look at the top of the slide, the other common feature is that all of these patients were inhibitor patients, and all of them were receiving concurrent high-dose repeat FIBA therapy. And then in February, there was another patient who developed a problem, again was receiving ACE910, Emicizumab, with FIBA, developed lab features of a thrombotic microangiopathy, and this patient actually succumbed to bleeding eventually. So there were these 5 serious adverse events which have taken place during a phase 3 study of this agent. I've returned to this original picture here just to remind you what Emicizumab does. So remember, it needs factor 9 and it needs factor 10 to produce its effect. And if you look on this next slide, this is one way of explaining probably what happened in these cases. Here, remember, these patients all received Emicizumab at the same time as high-dose repeated FIBA, and FIBA contains large amounts of factor 10, some factor 10A, and large amounts of factor 9 and some factor 9A. And so what I've tried to illustrate here on the right-hand side is that you would expect that these patients will develop significantly increased amounts of activated factor 10 and probably would be at risk of developing thrombotic problems, and that indeed happened. So I think when moving forward with this agent, which probably is going to happen, and you heard maybe this might be licensed in the States within the year, the use of FIBA with this agent will be highly, highly restricted. There were no problems with 7A with this agent. It was all with FIBA. So here you see the adult 8 inhibitor study is completed. It'll be shown in Berlin at ISTH. There's a pediatric inhibitor study which is in progress. And there are planned studies to look at adult non-inhibitor patients and to look at a monthly dosing schedule. By the way, the studies I showed you previously, I didn't mention this, were with weekly subcutaneous administration. So the New England Journal article I alluded to was weekly sub-Q. Okay, so moving quickly on to balanced hemostasis. This is what the hemostatic system looks like in normal individuals. It's in equilibrium. If you lose procoagulant factors like factor 8, you develop a bleeding problem. If you lose or you're congenitally deficient in an anticoagulant protein, you develop thrombosis. But if you have hemophilia, so here we're missing factor 8, but if you induce a deficiency of one of the anticoagulant proteins, like antithrombin, you can rebalance this equilibrium. So this is rebalanced hemostasis, and the next bunch of slides is going to discuss this. So you can do that either through Fitusiran, which is inhibiting antithrombin, or by inhibiting TFPI, or tissue factor pathway inhibitor, through antibodies, Concizumab, and other companies, including Bayer and Pfizer, are also working on programs to inhibit this anticoagulant. So you can inhibit antithrombin by reducing its production using a small inhibitory RNA, and I'll explain that in just a moment. You can inhibit its function with antibodies or other means, and TFPI can be inhibited using anti-TFPI antibodies. So here is the Fitusiran story. This is supposed to represent a liver cell. You deliver a small inhibitory RNA molecule, so a nucleic acid. It gets into the cell, and then in the cell, this RNA complexes with the messenger RNA of antithrombin and prevents the production of the protein. So this is a synthetic block that's being produced by a nucleic acid therapy. This works in a way that can be given by subcutaneous injection again. So this is not intravenous. It can work through sub-Q injection, and it can be given either weekly or monthly. So these are results from phase 1 in non-inhibitor hemophilia patients, and it shows you the levels of thrombin generation on the vertical axis. On the left-hand side is the thrombin levels in a group of healthy volunteers. And then you can see that depending on how low the antithrombin goes, you can actually approximate thrombin generation in normal individuals in hemophilia patients treated with Fitusiran. So I'm just going to go through the phase 2 study involving here 16 patients. These patients don't have inhibitors. You can see that the levels of antithrombin on the left-hand side that were achieved through monthly sub-Q Fitusiran were around about 20%. So this is an 80% knockdown or inhibition of antithrombin. And you can see on the right-hand side that the thrombin generation that was produced in these patients, again, was approximating the lower end of the normal range of peak thrombin generation. And then here you can see that with a median observation period of 5.7 months, that on the right-hand side, the annualized bleeding rates in these patients was significantly reduced from their previous on-demand bleeds of up to 25 ABR levels. So there was evidence of both thrombin generation and a reduced ABR in these patients without inhibitors treated with this agent. Now, for time purposes, I'm not going to go through the data with inhibitors. I don't have time to do that. This just shows you again that in those cases, again with monthly subcutaneous Fitusiran, the levels of antithrombin here are down again to about 20% levels. And this is the thrombin generation, which again looks very similar to what we saw previously in patients who did not have inhibitors. So this is in an inhibitor-positive patient population, showing that you can generate thrombin and therefore good clotting in the presence of anti-factor VIII antibodies. Okay, so I have just 2 slides on Concizumab, and then I'm going to finish. So Concizumab is an anti-TFPI antibody. This slide here shows you that on the vertical axis that when you get very low levels of free TFPI, so when you've given a lot of this antibody, which prevents TFPI from being effective, there are minimal bleeding events. So on the bottom of this slide, you see that most of these time points said that there were no bleeds, and it was only when TFPI was free in the plasma that there were bleeds that were recognized. And this just shows you that with increasing TFPI exposure, the levels of free TFPI are reduced for about 3 weeks after a sub-Q administration. So these novel alternative therapies really have shown very good initial reduction of clinical bleeding rates including, as noted by Dr. Karkeo, in inhibitor patients. The advantage is that they can be given by infrequent subcutaneous administration. There have been significant adverse events with Emicizumab, but that's always been when it's been co-administered with high-dose repetitive fever. And so I think we can explain that, and probably that effect can be mitigated going forward. There have been no neutralizing antibody developments to any of these therapies. Some of the questions are, how do you monitor these agents? That's very unclear at the present time. There's really no good laboratory monitoring. Most of these studies have been done under steady state conditions, and so the agents haven't been given to patients who are septic, following major trauma, with major bleeding events. How are they going to perform? Are they going to be safe in those conditions? And some of these proteins, like TFPI, are distributed in different places in the body, and you have to be a little careful about how you perturb those populations of where the protein are. So these are agents that have shown promise, are now undergoing phase 3 studies. There have been rare but severe adverse events with one of the agents, but under specific circumstances. And Dr. Teitel is going to talk about gene therapy in just a moment. And here's the future. So for the next 5 years, the opportunities to select treatments for your patients is always increasing, and is going to make you think very hard about how you individualize therapy. Thanks for your attention.